Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
Okay, so I've been reflecting on episode 2's presentation, which absolutely bamboozled me. And there's so many different ways to tackle that case. And I really feel like in doing a cognitive autopsy, I latched onto kind of the mucosal blistering skin diseases. And, I'd mentioned at the beginning of my discussion how characterization of the rash really leads the DDX. And the mucosal, the oral mucosal manifestations really took front and center stage for me. But in looking back, you did mention that patient had pustules when they came in, right, Mike?
That's right. Yeah, I think that's the best way I would describe it. It's also how dermatology described it. So
there you go. Yeah. So you fed that to me in the aliquots, but I generated nothing, and that's because I had no approach to basically diffuse skin pustules. I had a notes on diffuse skin nodules, and this was actually highly based on Robbie's notes from over at the CP solvers. So what I did after the session was I went back to my skin nodules note and tried to reconcile that with this concept of skin pustules, just so I can create a new framework for skin pustules. So I'm just going to go over that really briefly, and this is all on the website. So skin nodules are circumscribed skin elevation with depth up to 2 centimeters. That's pretty deep. This is touching the deeper skin layers. That is the dermis extending to the subcutaneous fat. And if you remember, the skin has the epidermis, the dermis, and the subcutaneous fat without kind of substratifying it further than that. The pustules, it's also skin elevation that's visible to the eye, but what you see when your eyes are drawn to are that like collection of pus or leukocytes. Depth is a little bit less than 1 centimeter, and this really touches the superficial skin layer, so the epidermis and the dermis. So in terms of comparing nodules and pustules, they both can touch the dermis, but it kind of makes sense that the pustule also affects the epidermis because you're seeing, with your eye, this collection of pus at the surface, but nodules are a little bit deeper, going down to the subcutaneous fat. So anyway, I basically was seeing this overlap between the two frameworks, the nodules and pustules. Both include the neutrophilic dermatoses, which I won't go into. That's a group of skin disorders. You can basically break out into Sweet syndrome and pyodermic gangrenosum. That really starts in the dermis, and that collection of neutrophils you see in that disorder actually will eventually end up developing into a pustular lesion. So it starts dermal and then it erupts into the epidermis and it's visible. But at the end of the day, think of it as a dermal lesion, and you'll see it in both disorders because the dermis is in the middle. So I won't kind of go on skin nodules, but going to the skin pustules, I came up with this framework from Up to Date, which is where I'd actually do the vast majority of my learning. There were really 4 diffuse skin pustule disorders that they mentioned. It was neutrophilic dermatoses, which I just mentioned, AGEP, which he presented to me, pustular psoriasis, and this is kind of as it sounds. You have like psoriaform papules and plaques, and those are studded with pustules. So that one's a little bit kind of easier to recognize, it seems. I hope I would catch it if I saw it in real life. The images that kind of make sense. You kind of see those the flaky skin lesions. And the last one is eosinophilic pustular folliculitis. And that one's a little bit unique in that folliculitis is the key word there. So in that disease, the pus is really like, around the follicles. And what there is this eosinophilic infiltrate kind of targeting the sebaceous glands, and those are located within the dermis. So anyway, a nice little mnemonic I came up with to kind of remember that for diffuse skin pustular disease was a nape. And that kind of makes sense because you can think of the nape of the neck being close to the upper back, and that's where you have some of the highest density of sebaceous glands on the skin. And that's important for that eosinophilic pustular folliculitis I just mentioned, which is a disorder really of attack of the sebaceous glands of the dermis. So anyway, so much more. It's all going to go on the website, but I just wanted to take kind of like a big picture reflection of where I could have taken a different turn in the case. And I think just recognizing skin pustules is a key pivot and not the mucosal lesions. I found that to be very helpful.
Yeah, I think that was great. And just add some anecdote, just looking at these pustules that, as they opened up, they were kind of very superficial ulcers. If you remember, the pathology showed a separation at the level of the epidermis and dermis. So exactly what you described here in terms of how deep these things go, we saw specific in this case too.
Very cool. So I guess that skin anatomy, the skin layer anatomy was actually helpful, Mike. I definitely never thought that was super important, but it seems like in dermatology land, that actually matters. And I think it kind of makes sense in putting together this differential. I think just going back to the basics there actually does help kind of guide the DDX generation in this case. And this is one of these frameworks I'm going to be pulling up, in real time when I see this next, because no doubt I'm not going to see a case like this for another, year or two, earliest.
Yeah, that's what the scheme is there for. External brain.
Yeah. Okay. I got a case for you. This one, I would say, is a little bit less bamboozling than the one that you presented me yesterday. I think it's really good bread and butter, so I wouldn't overthink anything. But it really goes back to like core principles of just medicine and understanding kind of what different things mean on kind of like blood work for anemia. The focus of the case is anemia. And yeah, I think there's going to be a lot of learning to come out of it. So it's a case from the hematology consult service in residency. This is a case of a man in his 80s who presented for chest discomfort. He was in his usual state of health when he developed, over the course of an hour, increasing resting chest discomfort and vague sense of feeling unwell while watching TV. He says he didn't want to take any chances with these symptoms, so he had his sniff call EMS, and upon arrival to the ED, his symptoms had actually resolved, he said. He had been feeling well prior. He said he had pretty decent energy level, no dizziness, no dyspnea ever. The vitals showed no fever, normal heart rate, normal blood pressure, and he was sitting well on room air. And his initial lab showed a white count of 4.7, hemoglobin of 5.6, and a platelet count of 110. And his EKG showed a known left bundle branch block. The ST segments for the left bundle didn't show any evidence of like a positive Scarbosa criteria, nothing like that. His tropes were pretty much flat, and then his serial ECGs were all reassuring. And for his past medical history, he had a non-ischemic heart failure with a reduced CF, multiple cardiovascular risk factors, including CKD, and then several hospitalizations for recurrent falls, resulting in him living at the SNF. And on exam, he was comfortable appearing, and cardiopulmonary exam, including his extremity exam, was normal. He did have some chronic pitting peripheral edema, but that was seemingly related to chronic venous stasis. He had those changes. So in summary, it was really a man in his 80s who presented with resting chest discomfort, a reassuring workup, not compatible with coronary occlusion, but he was found to have a severe anemia to a hemoglobin of 4.7 and a thrombocytopenia to 110. So I'm just curious, like, your reflex thoughts to that aliquot. A lot of free space kind of to give you before I give you more data related to the CBC.
Yeah, no, I think this is going to be a good one. I will just say that one of the things that is so overwhelming about anemia, even I think at any stage of training, but certainly still as a first year attending, is that the differential is so broad. And the fact that oftentimes there are really nicely packed schema, great textbook schemas, great schemas that you'll see everywhere, but they often break down because a lot of the schemas assume that every patient has one problem and one problem only. And a lot of the things they use to make these decisions sometimes can be influenced by multifactorial processes, especially processes that are pulling values such as the MCV in opposite directions. And it's important to remember that one of the strongest predictors of who's going to have anemia is age. And as we get older, we accumulate more problems that can all lead to anemia and can cause anemia through different processes. So just want to say that at any stage of training, if you feel overwhelmed by anemia, there's a reason why. It's just a really broad process. And so because of that, I think what's important to kind of keep in mind with anemia is that you often have to work through multiple schemas at the same time. And that really starts with context. So you've told me this is an 80-year-old gentleman. So this is an elderly guy, has many reasons that he can have anemia, many of them scary. And he additionally has CKD and he has heart failure. We know that CKD, independent of sort of everything else, can cause anemia through erythropoietin deficiency. And then we also know that it is an inflammatory state at the same time. And then we know similarly that heart failure, specifically with reduced ejection fraction, can lead to iron deficiency through both inflammation as well as poor absorption. So he's got sort of a scary age and then two things that I think can cause anemia on any day of his life. And so I'm expecting that there is most likely a single driver for the acute drop, but there probably is some multifactorial causes on the background. And so, that's, I think, just going to be important to consider. And then the second would be the fact that he has a bicytopenia that we'll talk about in a second. The question that sort of comes out of all of the things I just mentioned is, what is this gentleman's hemoglobin a week, a month, a year ago? Because I think that helps with that question of multifactorial versus, it's all something that happened in the last days to weeks to months.
Oh my gosh, what a masterclass. Everyone just listen to that again. I have some teaching that's pretty much identical to the first part of what you just said later on. So just beautiful, beautiful. I'm just going to give you the second aliquot. We'll just keep it going. All right. It's a pretty small one. He received 2 units of transfusion with good response of hemoglobin to 8.5. And then looking back at his old heme data, going back many, many years, his MCVs have been as low as 59, normally in the range of 60 to 62. More recently, over the past 3 years or so, his hemoglobin has spanned 6.5 to 8.5. Over the past year, his platelets are newly low in the 50 to 100 range. The immature platelet fraction at this presentation is only 1.9%. His retics are hypoproliferative with an index of 1.1. An old smear from a pretty recent hospitalization showed an increase in the distribution of RBC size and shape. And they call this anisopoikilocytosis. Say that 3 times fast. And then some neutrophilic nuclear atypical lobularity with scattered large platelets. Neutrophilic nuclear atypical lobularity. Going back to his chronically low MCV, again, usually in the 60 to 62 range, you see his MCV is gradually increased to 70 over the past year. So anemia is one of those diseases where the DDX can be broken down in one of a few ways, as you already alluded to. So before dissecting the info I just gave you, how do you personally think about anemia? And does this patient's concurrent thrombocytopenia influence how you approach the anemia?
Yes, let's go. Yeah, let's do it. And certainly the answer is thrombocytopenia does influence how you think about anemia. So I think, again, to go back, I think there's sort of 3 approaches that I have. It's kind of hold in my head at the same time and see which one kind of makes the most sense to start with. But there's acute versus chronic, or acute versus subacute chronic. There's hyperproliferative versus hyperproliferative. And then there's sort of the classic of, microcytic, normocytic, macrocytic, which I think is how it's most often taught in kind of any stage of training. And I think that often I start with the acute versus chronic, because I think that when you have an acute anemia, again, differential can always be broad, but that really makes you much more specific for either acute blood loss or subacute blood loss, or some sort of hemolytic process. And, a lot of the other issues you're not going to acquire fast enough to give you an acute anemia. Other things sort of, someone who had an obvious drug exposure recently, chemotherapy, of course, being the most obvious and classic. And then someone who's, critically ill, has sepsis, infected. We know that can cause an acute anemia, both from, sort of a double whammy of increased destruction and decreased production, which tends to be mild to moderate. So I think knowing the acuity is helpful, because if it's acute, then it really narrows your differential, and you really worry about those things first. If you had told me this guy's hemoglobin was 12 a week ago and now he's coming in at 5.5, I'm very concerned about bleeding, right? And you're telling me this is a gentleman who's sort of lived in a relatively anemic base. To live in the 6s and 7s is quite anemic for a long time. And so, hemolysis and bleed, still possible for sure, but less likely. And now I'm thinking, especially with the hyperproliferative, that's sort of where I move next. So I've acute versus chronic. We're now sort of in the chronic, subacute, and then now hypoproliferative versus hyperproliferative tends to be hypo when you're dealing with a more subacute chronic, just because of the processes. And so you're telling me again, it's hypoproliferative. And so then that helps me understand that, okay, there's something wrong with the production of red blood cells, and that can be an issue with the raw materials. It can be an issue with delivery of those raw materials. It can be an issue of the factory itself not working well, or things getting involved, toxins, and it can be a problem with other things being made instead of the thing that you need. And anemia and thrombocytopenia together acutely are scary for, a MAHA, right? You've got something that's tearing up red blood cells and platelets. And so generally, if you see like an acute anemia with an acute thrombocytopenia, even if it doesn't fit the illness script well, oftentimes you just kind of have to get a smear and hemolysis markers, because it's a terrible thing to miss. And that is sort of how it would present. When you're much more on the chronic and hyperproliferative side of things, then that is not so much a worry, at least sort of common things being common. And again, it goes back to kind of the bone marrow, and the bone marrow is having an issue producing multiple things. It's interesting. He does not have leukopenia, but his leukocytes are on the low side as well. I think they were 4,300, 40.
Yeah, like borderline. Yeah, something like that.
Depends on the assay, but where I practice, it's less than 4,000 would be a leukopenia. So it's not, it's not like he's in the 8 or 9s. He's kind of down there as well. And the thrombocytopenia is mild. So is there some sort of natural history? It's possible. And so, yeah, I think at this point, he's really microcytic. So now I think you can go finally to the microcytic, normocytic, macrocytic. And with an MCV in the 50s, thalassemia really has to be on your radar. Of course, that's going to be a chronic cause, but there's even iron deficiency in the sort of the most severe. It's hard to get an MCV into the 50s with that. It's, again, totally possible, but it's just something that, raises, again, another specter of something that maybe is multifactorial. This is a gentleman who may have thalassemia and then is now having another insult. And so iron deficiency, of course, is also on that list. And, you can see anemia of chronic disease inflammation there, but it doesn't tend to be. And then, lead poisoning is another classic cause of microcytic anemia. But I think in him, I think the MCV, and I think it's you're tossing me a bone here. The fact that it's rising is also important. in the opposite direction. So someone who is not anemic, but you suspect iron deficiency, a drop in the MCV, even if the MCV goes from 95 to 82, right? Both normocytic. That tells you something, right? That something's changed. And so this is a gentleman who I suspect has thalassemia. Could be wrong. And then I think there's another process now that's dragging that MCV up. And you've also mentioned that there's increased size, basically a large RDW, from what I understand. I don't know the fancy term on the smear, but I believe that's what that means. And so you've got something that's dragging. You've got now different sized red blood cells getting pushed out into the bloodstream, which you see with iron deficiency. You see it with other sort of arrests of nutrient use, and then the neutrophil multilobulation is also interesting. And again, with the thrombocytopenia and the kind of not quite relative, low normal leukopenia, I do worry that maybe there's something inherent to the bone marrow that's maybe not just hypoproliferative, but there's something else in the bone marrow. It'd just be a concern. Again, 80-year-old gentleman too, so the risks of malignancy go up. I don't know if you mentioned he's ever had chemo or radiation for anything else in the past. At this point, people often have accumulated lots of problems. It sounds like just CKD and HFrEF.
Yeah. I've kind of racked up a couple of different pieces of info I can kind of feed you before the next aliquot. Really great points on chronicity. No melena, nothing like that. No obvious signs of blood loss. No recent chemos. No recent antibiotics. Nothing like that. That was amazing. I need to pause. That was so good. You're just crushing this right now. I know what I was going to ask. Okay. What would you send at this point to kind of confirm some of your suspicions or just kind of get a fuller picture of what's going on?
I think it would be really nice to know this guy's and again, you might have already kind of mentioned this and I just glossed over. So has he sort of lived in the 6s and 7s for years to decades? Is this a year?
Yeah, just to clarify, over the past couple of years, I'd say 3 to 4, he's been pretty solid in kind of the 6.5 to kind of 8 range. And he's been in the hospital for kind of miscellaneous reasons like falls. But yeah, he's always pretty low.
Okay. And in the spirit of authenticity, it's obviously what you would do if you were the first person seeing this person. But I imagine there's been some workup done. And so I would just, again, in efforts of being transparent, and what we would actually do here is we'd look to make sure that what has been done, what hasn't been done. But
yeah, let me just I'll give you kind of, because there has been some past workup, and then of course we sent a little bit of new workup with him. I'm gonna withhold some of the new workup, but let me give you some of his old workup.
Sure. Yeah. And micronutrients would be the sort of the thing I would want to know, both iron and maybe copper, and then also B12 and folate and sort of the things that can make you macrocytic.
Okay, perfect. So on history, he says he has a blood disorder that runs in the family, basically confirming thalassemia is the cause of his chronic microcytosis. It's never been confirmed, but it's pretty likely. Haptoglobin is normal at 125, and LDH is only mildly high at 293. DAT testing is negative. Ferritin's low at 22. Iron is low at 33. TSAT is 15%. And then going back in the charts some more, his ferritin has been consistently lower than 40 for the past 2 years. And B12 measurements, this is all, direct B12 measurement, all within normal limits over the last 2 years. And the numbers specifically, sorry, I didn't bring the units with me, but 581 to 769, I remember we have the same assay. No methylmalonic acid or copper measurements were ever since. His vitamin D level has been low on 2 measurements, and TSHs have all been normal. And he, on chart review notes, he's had hemoglobins less than 7 on a handful of occasions related to the falls. Already kind of mentioned that. Yeah, at this point, it was clear we were dealing with kind of a chronic rather than an acute anemia, as you've alluded to. And there's really significant prolonged iron deficiency And yeah, what are we doing next for the patient? Just like overall, and we'll work up for the anemia. Just yeah, it sounds like you had some thoughts.
Yeah, I think there's a good teaching point in the iron studies there that you mentioned his ferritin's been less than 40. Um, and so, I mean, essentially already confirms iron deficiency. There's a lot of different cutoffs, though. Some as low as, a TSAT less than 15% or 20%, or excuse me, a ferritin less than 15 or 20, excuse me. And then as high as 40. But it's important to know that in someone who you suspect underlying inflammation, which I would say is this gentleman, a ferritin less than 100 generally means that even if you have inflammation on board, you have two things, one of them being iron deficiency. So kind of for multiple reasons, I agree this gentleman's been iron deficient, looks like for a very long time. Does beg the question, why is his MCV rising if he's just iron deficient? Because you'd suspect that would, continue to keep the MCV low. And again, I'm interested in the MCV because, he lives in the 50s. And so he's gone, you mentioned the 70s, right? So he's gone up 20 points. And you can imagine that if someone was at 80 or 85 and they went up 20, they're now macrocytic, right? So I think I'm still worried about the macrocytic causes. You mentioned no copper, no MMA. And then I guess just asking, kind of common things being common, does he have any sort of, alcohol, heavy alcohol history? He has the falls. It's just something important to ask about even in the elderly.
Sounds like you're asking because of kind of the rising MCV, and one of those causes being liver disease and alcohol use. Yeah, he doesn't have anything like that.
Okay, gotcha.
Yeah, so to summarize, really, as you've what you're kind of focusing on is kind of what I was focusing on, was kind of the rising MCV. And yeah, just to summarize, he had these like low vitamin D measurements. The B12s were normal, but he was like pretty iron deficient, and that's kind of all the information before the last aliquot, and kind of how we sent final work up and we made steps.
Okay, so I guess I gotta take it from here. So the vitamin D being low is also, just again, very common, could be unrelated, but malabsorption can lead to many nutrient deficiencies that then cause many different types of anemia. Iron deficiency being kind of classic, but B12 also common. So we're really solidly, interestingly, I know that we're dealing with an MCV of 72, but I think I'm actually going to classify him as having macrocytic anemia, relative macrocytic anemia, and I'm going to kind of latch on to that schema. And so, and actually the sort of multilobulated neutrophils now, I'm kind of thinking that, I didn't think about that at first, but that actually may also be responsible for the macrocytosis. So we already sort of mentioned the big ones: B12, folate, heavy alcohol use is very classic. And you'll see macrocytosis even in the absence of anemia with really heavy alcohol consumption. We'd mentioned copper deficiency, liver disease, and then the other thing that can do this is meds. You'd mentioned that there were no obvious medications. Methotrexate and hydrea would be kind of classic. And then thyroid also can do it. You mentioned the TSH is normal. And then the other big concern here is, myeloma and myelodysplastic syndromes would be kind of other classic causes of macrocytosis. And he has the relative thrombocytopenia. He's an 80-year-old gentleman. I think, honestly, we could send, you could send an MMA and a homocysteine, but I think at this point, you could send an SPEP, and, you already got the smear. You could send, I don't know, flow, but I don't see anything on the smear. I would just get a bone marrow biopsy at this point. I think that I'm concerned about something in the marrow that shouldn't be in the marrow. So maybe, SPEP, homocysteine, MMA, and then marrow would be what I'd ask for, and the hematology service would ultimately grant permission or not.
Yes, why we were consulted in the first place. Like, okay, this guy keeps coming in with these really low hemoglobins. I think we should talk to hematology, and that's how we got there. Yeah, you took us home, Mike, with all the major points I kind of wanted to touch on this case. It's really I'll get to it in a sec. I'll just do the case resolution really quick, and then we can touch on it. But you really hammered this home so well. So his last colonoscopy was 10 years ago, and it showed hyperplastic polyps and a tubular adenoma. And we sent some methylmalonic acid that came back high at 0.86 micromoles per liter. And for our hospital, that signified mild B12 deficiency. And copper came back normal. They scoped him, and he did have a large duodenal polyp, multiple gastric polyps. The duodenal polyp was removed. And then, unfortunately, he had a poor prep for the colo portion of the exam, so that was non-diagnostic. We gave him IV iron, oral B12, and discharged him with steady counts. So I have three kind of categories of teaching points related to the case. And teaching point number one, you've hammered home so strongly already. So the utility of the MCV. So what is the MCV? So the MCV stands for the mean cell volume, and that measures the average size of red blood cells. And when assessing anemia, using the MCV to stratify the DDX is probably the most common framework I see. And I think, as you mentioned, it's a great way to create an exhaustive list of diseases. It can be further subdivided by retics being high, either high or low. But as you already mentioned, this framework in a vacuum can really be misleading, because if you focus in on a patient's isolated MCV finding, you may not think of diseases in the other MCV buckets. So for our patient with a chronic severely low MCV, you can see how it can be hard to zoom out and consider other causes like normo and macrocytic causes, but you were right there on the money. And in cases like this one, where you have the chronically low or high MCV and worsening anemia, it's important to look at that trend and kind of start taking in those diseases from the opposite end of the spectrum if you see that change. And a kind of another way to think about this and how you can be fooled if you're not paying attention is, as if you start extremely high on one end of the spectrum, like low or high, the MCV will kind of falsely reassuringly normalize. So you can like start really low, and then this guy's MCV being 70 eventually would have, hit 80 and been quote normal, right? And then you're kind of like stuck in the middle. It's not very helpful. So that's just one way you can kind of get tripped up. So teaching point number two is kind of about testing for B12 deficiency. And you had picked up on the blood smear finding of the increased lobularity of the nuclei of the neutrophil. It's kind of like that buzzword for B12 deficiency and like the megaloblastic anemia as we talk about for macrocytic anemias. So you were right there. It's just the B12 deficiency is hard to diagnose if you're using that B12 measurement you do at the lab, because it turns out there are a ton of reasons why serum B12 levels can be falsely high. So the deal with B12 deficiency is this, and this teaching is actually courtesy of the Blood Project's Bill Iard, who's one of my favorite educators on Med Twitter. So serum B12 measures the level of not one, but both forms of B12 binding proteins in the blood. These are called haptocorin and transcobalamin. Haptocorin is made mostly by myeloid cells. For this reason, several hematologic diseases and cancers can cause high haptocorin secretion and therefore high B12 measurement. The other binding protein, transcobalamin, binds the haptocorin, and that complex together is actually taken up by the liver. And leftover binding proteins are cleared by the kidneys. So what that leaves you with is kidney and liver disease can cause high B12 measurement. Kidney disease through low clearance, liver disease through low uptake or release of B12 stores if there's liver damage. And then finally, inflammatory diseases can cause high B12 through increased synthesis of those binding proteins. So end of the day, if you have high suspicion for B12 deficiency, which as you actually had in this case, because you mentioned the lobularity of the neutrophils being a little bit atypical, from my perspective, the low vitamin D can be nonspecific, like you said, but when you start seeing all these things line up, kind of like iron deficiency, vitamin D deficiency, and then plus or minus B12 deficiency, I'm always sending like all of the nutrient studies at that point. You mentioned copper, like we did that too. So once you kind of start seeing all those things line up in a row, you're definitely wanting to send kind of the whole panel to make sure you're not missing something. So it's in that instance, you would want to really do the more sensitive test, the methylmalonic acid. And then teaching point number 3 is iron deficiency usually leads to reactive thrombocytosis. And that could be pretty extreme. It could be like a million, like your platelets can literally go up to a million. And this patient had thrombocytopenia, not thrombocytosis. So in this case, it was kind of a red flag. There was a superimposed platelet production issue on top of the known iron deficiency. And the very low immature platelet fraction was supportive of the marrow production issue. And you were right on the money with that too. So that was this atypical journey. What are your reflections and thoughts?
I think it's once again a good example of common things are common. And you're not just because you think you've overturned a stone doesn't necessarily mean you have. And I do actually pretty seldom see MMA ordered, but that is the teaching for a reason. I didn't know that about the assay. That's actually super interesting, the fact that there's 2. And that actually, I have heard that B12 elevated, without explanation. You are a little bit worried about the myelodysplastic syndrome. And now I know why. So that was a really solid teaching point that I'll definitely, that's stuck in there now. I'm wondering what the team's thought was on the thrombocytopenia, because I think that is what made me push much closer to wanting tissue, wanting marrow, rather than treating empirically, for exactly the reasons you said, and that the iron deficiency didn't seem to fit with that.
Yeah. I think it was more that, as you mentioned, common things being common, B12 deficiency being just a unifying diagnosis was in the realm of possibility, and they wanted to see just how you would do with treatments. And then they definitely wanted to see him in the outpatient setting again to make sure that he wasn't, on supplementation, making sure he's taking the supplements, that he's not having this ongoing macrocytic anemia that's then worrisome for MDS, like you mentioned. So yeah, I think definitely that was on their mind. They just kind of wanted to do that first pass and see how he did, and then they can kind of take it from there.
And I think that's a great management teaching point, that especially as hospitalists and the residents that are rotating, and med students, that are rotating through the wards, you don't have to get to the final answer in that hospitalization, just as long as you have eyes on the outside that will continue to look for that endpoint diagnosis if it's not found. And then the tincture of time is a real, it's treatment, but it's also diagnostic, in that if this normalizes back to his relatively abnormal baseline, then maybe you have your answer. Although I'd still say that you probably have to go looking for, he now has 3 micronutrients, including the vitamin D, that are low. And so probably needs some sort of understanding of poor, why is he malabsorbing so poorly? It could just be the HFrEF, which is common. But yeah, hearing that it was not just a discharge to the community, and that hematology will see him, that makes much more sense then, that you would give him sort of the obvious treatment that his labs are telling you he needs, and then see how he does and make decisions from there to save him a marrow if he doesn't need it. So that makes perfect sense. That helpful context for a management side. Thanks.
Yeah, of course. I think you entertaining MDS kind of over and over and over again, I think, just to go back to your teaching point from earlier, it makes sense that you're thinking about it over and over and over again, because as you said, Hickham's dictum really predominates with anemia. Like, you can have so much going on. So wouldn't be surprising if he got the supplements and then didn't do great in a couple months. So yeah, anemia is just one of those things where you got to kind of run the whole DDX, and just you're checking boxes. You're sending a lot of things and trying to see what's contributing, and then hopefully you land in a place where you feel like you've gotten kind of everything. But yeah, thanks again for playing, Mike. Excellent discussion.
Oh, absolutely. And I will say that I've seen it before, that you can get a micronutrient deficiency in the setting of myelodysplastic syndrome, leukemia, just because you have so much consumption of the micronutrients to drive that process. Wouldn't really make sense in this case, because you're not seeing anything in the blood. You'd expect them to really be leaching a lot of abnormal cells into the blood on that smear if he was using it to that degree. But that is something that you can see, right? Just you have only so much iron, and you have only so much B12 and folate, and if you're burning through the reserves, making leukemic cells, then you can see that. Of course, you also have malignancy inflammation. So as we go back to it is often multifactorial, which is why this is tough.
I love it. Thanks again, Mike.
Absolutely. Thank you. That was great. This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.